Hi, my name's Leila Ali. I'm one of the IMT1 doctors at Southend Hospital. I worked on this QI project over a period of 6 weeks in October and November last year while I was on my geriatric rotation alongside my colleagues Myron, Muna, Florence, and Larita. Today we'll go over the aims of the project, the background, methods, results, and conclusions, and then have a bit of a discussion in the end as well. So the main driver behind carrying out this project was listening to frequent complaints from junior doctors being called on while they were on call to review either a new or evolving skin lesion, often of an elderly patient, and then experiencing that frustration when there was no baseline skin assessment to compare to, particularly in an event where a history was difficult to get because of cognitive impairment of a patient. So when patients are initially clerked into hospital, a thorough examination usually happens, including a respiratory, cardiovascular, abdominal, and often even neurological examination, which means when later on daily ward rounds or during on-call assessments are made, comparisons can quite easily be made, whether there's, say, for example, a new murmur or changes in the lung sounds, or if the calves are still soft and non-tender, etc. However, skin assessments are generally poorly performed and maybe actually just poorly documented. So then it becomes difficult to make comparisons and be able to understand whether a lesion is new or changing. The broad aims that we're looking at were, number one, to find out how well were doctors assessing skin and documenting these assessments. Number two, to find out how well nurses were assessing the skin and documenting. And number three, if a gap was found in either of these groups, was there room for improvement based on our potential findings? So apart from the inconvenience for the on-call doctors, why are skin assessments so important in our elderly patients? Well, assessment of the skin is an important aspect of the physical domain of the comprehensive geriatric assessment. The CGA is a systemic approach to assessing the health and functional status of older adults, with the goal of identifying and addressing their specific needs and problems. As part of the CGA, skin assessments play a crucial role in detecting and preventing skin-related complications in geriatric patients. The skin is the largest organ in the body, and its condition can reflect the overall health and well-being of an older adult. Skin changes are common in older age, and the prevalence of skin disorders and injuries is higher in geriatric patients. Common skin-related complications that elderly patients are at risk for are pressure ulcers, skin tears, incontinence-associated dermatitis, purpura from anticoagulation and steroid use, and venous stasis eczema, which put patients at high risk for developing infections. Risk factors for these skin-related complications include age, immobility, incontinence, poor nutrition, and certain chronic medical conditions. It is important to remind ourselves that there are implications of skin-related complications in geriatric care, including both the quality of life of these patients as well as the healthcare costs with managing these complications. The method used was a quality improvement project. It took place on the 2 geriatric wards of Southend University Hospital, which are called Chalkwell and Balmoral, and have a total of 57 patients across both wards. All doctors on the care of the elderly team were asked to participate after the initial baseline data was collected. The baseline data was important because it provided a starting point for the interventions that were implemented later on. What was found that out of the 33 patients on Chalkwell ward, only 9% of assessments were being performed by doctors and around 85% by nurses. And of the 24% on Balmoral, of the 24 patients on Balmoral, 25% of assessments were being performed by doctors and 75% by nurses. So the majority of skin assessments were being carried out by nurses on both wards. And it was clear that we needed to carry out interventions focusing on improving awareness and performance of skin assessments in doctors. Data was collected over a 6-week period. Each intervention was carried out on a fortnightly basis on a Monday, and then data was collected twice a week, Tuesdays and Fridays. This was to see whether there was any difference in compliance to performing skin assessments between the days which were very soon after the intervention and the days which were kind of in the week later on. The first intervention was in the form of a verbal announcement at the morning meeting where most of the team was present. The gaps noted in doctors' documentation were highlighted, and the importance of regular skin assessments in elderly patients was emphasised. Staff was informed that documentation could also just be in the form of referring to nursing notes or mentioning whether there were no acute findings, similarly to how they document findings of other systems. Following this intervention, the number of skin assessments carried out by doctors increased. The largest increase of over double was seen in the day following the intervention, from 16 to 40%. But this steadily declined over the course of 2 weeks, and before it was time for the next intervention, only 23 of these skin assessments were being completed across both wards. 2 weeks after the first intervention, a teaching session was arranged at the morning meeting, which was led by one of the tissue viability nurses. She engaged the staff in a discussion regarding their views on skin assessments, the importance of carrying them out, and who to contact in events of concerns. This, however, resulted in an overall decline in skin assessments on both wards. The largest frequency was still seen on the day following the intervention, so the day after, where 16% of total assessments were being performed across both wards. But this was around the same value of the initial baseline data, which meant that there was actually no significant improvement. Then lastly, the third intervention involved putting up posters with information and a reminder regarding skin assessments on the walls of the doctors' offices of Chalkwell and Balmoral ward, as well as sending them out in the DME WhatsApp group. Surprisingly, on the day following the intervention this time, the numbers of assessments carried out by doctors was 0. And again, there was no significant improvement in this PDSA cycle. The compliance rate eventually increased to 21% by the end of the intervention. But overall, the poster intervention did not seem to have a positive impact on increasing the number of skin assessments performed by doctors on either ward. So based on the data collected and analysed through the PDSA cycles, we were able to conclude that there was initially a significant difference between the number of skin assessments carried out by doctors and nurses on the 2 wards. The first intervention, in the form of a verbal announcement regarding the project and the importance of regular skin assessments, resulted in a significant increase in the number of assessments carried out by doctors. However, the subsequent interventions did not have a significant impact on the numbers of assessments carried out. Overall, the data suggested that regular education and reminders regarding skin assessments are important in maintaining high levels of compliance, and that a one-off intervention is probably not enough and not sufficient enough to sustain improvement. It also highlights the importance of ongoing data collection and analysis to monitor the effectiveness of interventions. All in all, while our interventions did not result in a significant increase in the number of assessments carried out by the doctors, we believe that our efforts have raised awareness of the importance of regular skin assessments in older adults and may have contributed to an overall increase in the number of assessments carried out. Moving forward, we recommend that ongoing efforts still be made to ensure that all members of the geriatric team are aware of the importance of regular skin assessments, and that protocols be put in place to ensure that these assessments are carried out consistently across all patients. This may include ongoing education and training for staff members, as well as regular audits to ensure that assessments are being carried out as intended. Ultimately, our goal is to ensure that all older adults under our care receive timely and appropriate skin assessments in order to prevent the development of pressure ulcers and other related complications. There are guidelines and recommendations for skin assessments out there. NICE has published clinical guidelines on the prevention and management of pressure ulcers, which do include recommendations for skin assessments in geriatric patients. Some of the key points from these: so number 1, all patients should have an initial skin assessment on admission to a healthcare facility, which should include a full body examination of the skin and documentation of any areas of concern. Number 2, patients at risk of pressure ulcers should have ongoing skin assessments at regular intervals, with the frequency determined by their individual needs and risk factors. These assessments should also include a visual examination of the skin, noting any changes or signs of damage, and a review of the patient's medical history and care plan. Number 3, all patients should be assessed for their risk of developing pressure ulcers using tools such as the Waterloo or braided scale. Number 4, all skin assessments and pressure ulcer risk assessments should be documented in the patient's medical record, along with any interventions or care plan that have been put in place. And lastly, number 5, skin assessments and pressure ulcer prevention should be a multidisciplinary effort with input from not only nursing staff, but also medical staff and other healthcare professionals. It's important to note here that these guidelines, although they're specific to pressure ulcer prevention and management, but the principles of skin assessment outlined in these guidelines can be applied more broadly to the care of geriatric patients. Thank you for listening.